In the silent depths of the human body, an unseen architecture of billions of cells sustains us. Yet within this intricate design lies the potential for devastating betrayal. We speak of breast cancer, not merely a disease, but an uncontrolled uprising of abnormal cells, the single flaw, a mutation in the DNA that allows a cell to bypass the body's ordered signals, defying the imperative to die, and instead choosing relentless exponential growth. These renegade cells aggregate, forming a primary tumor that, if left unchallenged, learns to invade surrounding tissues. The true peril lies in metastasis, the terrifying journey where these cells break free, navigating the bloodstream or lymphatic system to colonize distant organs, transforming a localized threat into a systemic catastrophe. Understanding this process, this cellular rebellion, is the first terrifying step towards acknowledging the weight of the challenge.
To confront this adversary, we must first grasp its magnitude. The statistics are stark, immutable markers of its reach. Breast cancer stands as the most frequently diagnosed cancer globally, casting a long shadow over millions of lives each year. While often discussed in relation to women, its indiscriminate nature means that men, though less frequently, are also vulnerable to its onset. The data reveals a terrifying truth. Approximately 1 in 8 women will face this diagnosis in their lifetime. These figures are not just cold numbers. They represent shattered lives, fractured families, and the collective societal burden of relentless medical warfare. Furthermore, the statistics show significant disparities across demographics and access to care. Mortality rates are often higher in underserved communities, emphasizing that the battle against this disease is interwoven with socioeconomic realities. We cannot afford to look away from these figures. They are the drumbeat demanding vigilance and equitable access to necessary screening and advanced treatment protocols.
The seeds of vulnerability are often sown long before conscious awareness, embedded deeply within our personal history and genetic code. Certain risk factors are immutable, uncontrollable determinants that predispose individuals to higher risk. Age is the foremost factor. The sheer passage of time increases susceptibility, with the majority of diagnoses occurring in women over 50. Then there is the specter of genetics, specifically mutations in genes like BRCA1 and BRCA2, which dramatically elevate the lifetime risk, serving as an inherited ticking clock. A dense breast tissue composition, which makes detection via mammography inherently more challenging, is another significant physical risk factor. Furthermore, reproductive history plays a role. Early onset of menstruation or late-age menopause extends the exposure time to fluctuating hormones, potentially fueling abnormal cell growth. A strong family history, especially in first-degree relatives, casts a persistent shadow, necessitating heightened surveillance. We must accept these inherent risks, not as inevitable doom, but as crucial data points informing an aggressive, personalized screening strategy.
While certain risks are inherited, a significant portion of vulnerability stems from the daily choices we make, the environment we inhabit, and the subtle toxic exposures we endure. These are the modifiable risk factors, areas where focused self-discipline and conscious modification can potentially shift the odds. A sedentary lifestyle, devoid of consistent physical activity, weakens the body's innate defense systems and contributes to unfavorable metabolic profiles. Obesity, particularly post-menopause, leads to elevated levels of estrogen produced by fat tissue, providing hormonal fuel for cancer development. Chronic excessive alcohol consumption is a documented risk enhancer, even in small amounts, contributing directly to cellular damage. Postmenopausal hormone replacement therapy, while alleviating certain symptoms, must be weighed against its established connection to increased breast cancer risk, particularly with prolonged use. Finally, smoking, the insidious destroyer, compounds risk across all cancer types. Confronting these lifestyle factors requires acknowledging that we are not passive recipients of fate, but active participants in managing our long-term health narrative, demanding consistent effort and sacrifice. The body often whispers warnings before it screams in crisis. Recognizing the early symptoms of breast cancer is paramount.
demanding a mindful intimacy with one's own physical form. The most commonly recognized sign is the discovery of a new lump or mass, one that feels distinct from the surrounding tissue, often described as hard, immovable, and sometimes irregularly shaped. However, reliance solely on lumps is perilous. The warning signs can be far more subtle. Changes in the skin of the breast, such as dimpling, puckering, or redness that resembles the texture of an orange peel, pot orange, are critical red flags indicating advanced involvement. Any unexplained swelling or change in the size or shape of the breast, particularly if asymmetrical, must be investigated. Nipple changes are equally serious. Inversion, scaliness, crusting, or, most alarmingly, spontaneous nipple discharge that is bloody or clear. Persistent pain, while usually benign, should never be dismissed if localized and unexplained. Ignoring these signals, attributing them to minor discomfort or aging, allows the darkness to deepen. True self-preservation demands immediate professional assessment upon detection of any anomaly. Early detection is the most powerful weapon in the arsenal against mortality. Screening procedures are not mere medical suggestions. They are vital, scheduled acts of self-defense designed to catch abnormalities when they are small, localized, and most treatable. The mammogram, utilizing low-dose X-rays, remains the gold standard, capable of visualizing microscopic calcifications or tiny tumors long before they are manually palpable. Adherence to a consistent screening schedule, typically annual or biennial starting at age 40 or 50, depending on risk profile, is non-negotiable. Furthermore, clinical breast exams performed by healthcare professionals provide an added layer of scrutiny, utilizing expert tactile assessment. Crucially, the breast self-exam, while not replacing professional screening, cultivates body awareness. It trains the individual to recognize their normal texture, making even slight deviations immediately apparent. For high-risk individuals, supplementary screening tools such as MRI or specialized ultrasound may be employed to pierce through dense tissue. Compliance with these screening guidelines transforms uncertainty into proactive vigilance, providing the critical time advantage necessary for successful intervention.
Once an abnormality is detected, a suspicious mass on a mammogram or a palpable lump, the investigative phase begins, moving toward definitive diagnosis and classification. This stage is crucial, determining the precise nature and extent of the threat. The core diagnostic tool is the biopsy, the moment of truth where a small sample of the suspicious tissue is extracted, usually guided by imaging, and sent for rigorous pathological examination. Pathologists determine whether the cells are malignant and, critically, analyze their characteristics, the grade, how aggressive they look, and the receptor status. Receptor status, checking for estrogen receptors, ER, progesterone receptors, PR, and the HER2 protein, is foundational, dictating the entire subsequent treatment strategy. Following diagnosis, staging determines the extent of the cancer's spread, utilizing the TNM system: tumor size, node involvement, metastases. Stage 0 represents non-invasive disease, while Stage 4 signifies metastatic cancer, having spread to distant organs. This precise staging and receptor mapping transforms an ambiguous threat into a defined, targeted enemy profile, allowing oncologists to formulate a tailored, often aggressive, battle plan.
For localized disease, surgical intervention often forms the cornerstone of the primary treatment strategy aimed at the physical eradication of the tumor. The choice of procedure is determined by the tumor size, location, and the patient's preference and body type. The lumpectomy, or breast-conserving surgery, removes only the tumor and a margin of surrounding healthy tissue, striving to preserve the majority of the breast structure. This approach is almost always followed by radiation therapy to eliminate any microscopic residual cells in the preserved tissue. Conversely, the mastectomy involves the full removal of the entire breast tissue. While historically more common, modern oncology now aims for the least invasive, effective treatment. In either case, critical attention is given to the lymph nodes, usually sampled or removed, sentinel lymph node biopsy or axillary dissection, as their involvement indicates the path the cancer has taken towards potential metastasis. This surgical confrontation is a physical intervention of immense emotional weight, demanding resilience and careful reconstructive planning to address both the clinical outcome and the subsequent psychological impact on body image and self-perception. Beyond surgical removal, the systemic and targeted therapies are designed to eliminate cancer cells that may be circulating throughout the body, providing microscopic insurance against recurrence. Chemotherapy, perhaps the most notorious treatment, uses powerful drugs to destroy rapidly dividing cells, impacting both cancerous and healthy tissue, leading to well-known severe side effects, but often achieving crucial systemic control. Hormonal therapy, however, is a precise weapon, reserved for cancers that test positive for hormone receptors, ER+ or PR+. Drugs like tamoxifen or aromatase inhibitors work by blocking the cancer cell's access to estrogen, effectively starving the tumor of its primary growth fuel, often administered for many years post-treatment. Targeted therapies, such as those aimed at HER2-positive cancers, are the pinnacle of modern specificity, utilizing antibodies to lock onto and destroy cells overexpressing that specific growth protein. Finally, radiation therapy, often used post-lumpectomy, bombards the local area with high-energy waves to sterilize the remaining tissue, drastically reducing local recurrence risk. These multimodal strategies showcase the complexity of the current fight, demanding patience, endurance, and faith in targeted science. The journey does not end when active treatment concludes. It shifts into the often challenging phase of survivorship and long-term surveillance. This period requires a fundamental restructuring of life, moving from the intense focus of treatment to the sustained vigilance of follow-up care. Regular monitoring is essential, involving scheduled physical exams, blood tests, and imaging to ensure early detection of any recurrence. Oncologists tailor survivorship plans, which often include continued hormonal therapy, addressing the long-term side effects of radiation or chemo, such as fatigue or peripheral neuropathy. Crucially, survivorship is deeply interwoven with quality of life. The psychological and physical scars necessitate robust rehabilitation, focusing on restoring mobility, managing lymphedema, and rebuilding strength. The fear of recurrence, often called the sword of Damocles, is a constant psychological companion that must be managed. Embracing this new normal means adopting rigorous healthy habits, acknowledging the lasting impact of the experience, and finding strength in the identity of the survivor rather than the victim. The weight of a cancer diagnosis and the arduous path of treatment cannot be carried alone. The psychological toll is profound, encompassing anxiety, depression, body image issues, and fundamental challenges to one's sense of self and mortality. Therefore, robust support systems are not secondary comforts, they are essential pillars of treatment. Access to specialized psychosocial oncology care, including therapy and counseling, helps survivors process trauma and manage the chronic stress associated with their prognosis. Support groups offer an invaluable sanctuary, a place where shared experience validates fear and fosters community, mitigating the isolation that often accompanies serious illness. Furthermore, the role of friends, family, and intimate partners becomes critical, requiring them to transition into compassionate caregivers, balancing emotional support with practical assistance. Financial and logistical support services are equally vital, alleviating the overwhelming burdens of appointments, travel, and medical costs. We must ensure that infrastructure exists to nourish the mental and emotional resilience of every individual navigating this diagnosis, recognizing that holistic healing encompasses the spirit as well as the body. We conclude this intensive exploration with a somber understanding of the enemy we face. Breast cancer demands eternal vigilance, fueled by knowledge and proactive engagement. The message is clear and unwavering. Understand your individual risk profile, adhere rigorously to recommended screening schedules, and pay constant, critical attention to the subtle signals your body provides. Early detection remains the most decisive factor in positive outcomes, translating directly into higher survival rates and less aggressive treatment requirements. The progress in treatment, from precision surgery to hyper-targeted systemic therapies, offers immense hope, transforming this once terrifying diagnosis into a survivable chronic condition for many. Your health narrative is yours to control, armed with the information discussed here. Take this knowledge, share it, and turn awareness into action for yourself and those you love. The battle is ongoing, but your preparedness is the best defense against the silent threat. Don't forget to like and subscribe for more updates.